Dear doctors, welcome to the INI-CET May 2022 recall session. So we had around 25 questions from obstetrics and gynecology in this INI-CET exam. The number is a little higher when compared to the other INI-CET exams. Overall, I would say the paper was tough. Paper was really tough, and questions were from certain topics which are not very common, which are not commonly taught in the undergraduate period. Okay, so we had 4 to 5 questions which are really tough even for a postgraduate student in obstetrics and gynecology. So those questions are not the deciding questions. Okay, if you were able to answer the common questions out of the 25, if you were able to answer around 16 or 17, that is a reasonable job, I think. Okay, so we'll begin with a very easy and a very simple question. The question is like this: which of the following is not a cost-effective screening test done routinely in pregnancy? Okay, which of the following is not a cost-effective screening test done routinely in pregnancy? I think this question doesn't require any explanation at all, because you all know what all we commonly do during pregnancy in the antenatal period in the first visit or the booking visit. Okay, but for completion's sake, let me tell you a few points on this. So for completion's sake, let me tell you a few points on this. What all investigations do we commonly do during the antenatal period? These are the investigations which are mandatory. Okay, these are investigations which are mandatory. These are mandatory investigations, and these are must-do investigations during pregnancy, especially in the booking visit, and they are hemoglobin, hematocrit, blood grouping and typing, blood glucose, VDRL, HIV, HbSAg, urine microscopy, and of course urine culture too. Okay, so blood glucose, when I say blood glucose, it can either be a glucose challenge test or a glucose tolerance test. Depending on the prevalence of diabetes in that community, you would either go for a screening test called oral glucose challenge test, or you would go for a confirmatory test called oral glucose tolerance test. Either of this is okay. Fine. So blood grouping and typing, you all know how important it is to detect Rh negativity during the antenatal period in order to prevent the mother from getting sensitized. Okay. And hemoglobin and hematocrit, of course, to correct anemia during pregnancy. VDRL we do because syphilis is a congenital an infection which can spread from the mother to the baby and cause anomalies in the baby, right? So VDRL is important. HIV to prevent vertical transmission. Again, HbSAg to prevent vertical transmission. Urine microscopy is definitely required because we need to, detect a condition called asymptomatic bacteriuria during pregnancy. Okay, asymptomatic bacteriuria during pregnancy. Okay, now what does this asymptomatic bacteriuria do? Yes, it has got its own complications during pregnancy. Asymptomatic bacteriuria can lead to pyelonephritis. Okay, can lead to pyelonephritis. It can also lead to preterm labor. Okay, it can also lead to preterm labor. So it is important to treat asymptomatic bacteriuria during pregnancy, and for this reason, yes, urine microscopy should be done for all pregnant women as early as possible during pregnancy, ideally in the booking visit. Okay. Now, asymptomatic bacteriuria is one thing that you will identify by doing urine microscopy. The other thing is proteinuria. So, why is proteinuria important? You all know that there is a condition called pre-eclampsia where proteinuria is one important feature. And in case there is proteinuria, yes, the woman will develop edema, and there are chances that the baby will develop IUGR. Okay, so proteinuria again is important. For these reasons, yes, urine microscopy is a very important investigation that has to be done during pregnancy. And in case there is any problem with urine microscopy, urine culture has to be performed to detect asymptomatic bacteriuria. Okay, so these are investigations that are mandatory during pregnancy. So when you see this list, some of you might wonder why there is no TSH here, right? Because TSH is one important investigation which we routinely do in the booking visit, in the first visit. Okay, so if you ask me whether TSH is mandatory, is it a must-do investigation during pregnancy? No, TSH is not a mandatory investigation. It is not a must-do investigation, but TSH is important during pregnancy. Okay, so there are certain investigations which are not mandatory, but still they are commonly performed. Okay, other common investigations. These investigations are not mandatory but are commonly performed, and they are serum TSH. Number 1, serum TSH. The second is rubella, IgG and IgM. Why? Because we know rubella is again a teratogenic virus. No, it causes anomalies. So it's important to prevent rubella related congenital anomalies in the baby. So rubella, IgG and IgM is another investigation which is commonly performed, and screening for hemolytic anemia only in endemic areas where hemolytic anemias are prevalent, like say sickle cell anemia, thalassemia. There are certain states in India where thalassemias and sickle cell anemias are commonly seen. So there, yes, we do screening for hemolytic anemias as well. Okay, so these are investigations which are commonly performed, and these are investigations which are routinely performed. Okay, fine. So what is the answer for this question? Which of the following is not a cost-effective screening test done routinely in pregnancy? HIV is done, VDRL is done, yes, sugar screening is done, echo is not routinely done. Okay, echo is done only for selective women, not for all women. Okay, so we'll move on to the next question here. Which of the following is not a criteria in the diagnosis of preterm labor? Not a criteria in the diagnosis of preterm labor. Okay, so here you need to know how we diagnose preterm labor. Okay, so what is the definition for preterm labor? Onset of labor before 37 completed weeks is preterm labor. Okay, so onset of labor before 37 completed weeks is preterm labor. Now we have two types here. Okay, one is threatened preterm labor and the other one is established preterm labor. Okay, so what is threatened preterm labor? Threatened preterm labor is where there is only contraction and there are no cervical changes. Okay, so only contractions are present and not cervical changes. That is threatened preterm labor. What is established preterm labor? Established preterm labor is a condition where contractions and cervical changes both are present. Okay, both cervical changes and contractions are present. Okay. So here we have a criteria to diagnose preterm labor, and it goes like this. According to this criteria, there should be contractions which are regular. Okay, so the first important criteria is what? Regular contractions. Okay, regular. How many in number? At least 4 contractions in a 20-minute period, or at least 8 contractions in 60 minutes. Okay. So regular contractions, at least 4 in 20 minutes or at least 8 in 60 minutes with a cervical effacement of 80%. Okay, cervical effacement of 80% and or a cervical dilatation of more than 1 centimeter. Okay, so this is what the criteria says. Okay, so this is the criteria to diagnose preterm labor. Okay. We have classification here. We have something called early preterm, late preterm, near term or early term and term. So less than 34 weeks is early preterm, 34 to 37 weeks is late preterm, 37 to less than 39 is near term or early term, and 39 onwards it's term. So for those of you who are wondering that term is more than 37, anything more than 37 is term, yes it is, yes. Okay, anything more than 37 is term, and that term only is divided into early term and term. Okay, so just don't get confused. If at all the examiner asks something like this, if she mentions any word like early term or near term, just remember that 37 to less than 39 is early term or near term, and 39 and above is term. Okay, so fine. So you understood the criteria to diagnose preterm labor. So which of the following is not a criteria? That's the question here. Cervical dilatation more than 1 centimeter is a criteria. Cervical effacement of more than 80% is definitely a criteria. 4 contractions in 20 minutes, 8 contractions in 60 minutes is definitely a criteria. Posterior cervix is not a criteria. Okay, posterior cervix is not a criteria. Okay. So next question on preterm labor again. The cerclage procedure that is done for a non-pregnant woman. Non-pregnant woman. Okay. So this question again is a very easy and a straightforward question. So you need to know a little about different cerclage procedures. Okay. So what are the types of cerclage? What are the types of cerclage? Okay, so first of all, what is cerclage? Cerclage is the suture that is applied to the cervix in order to prevent preterm labor. Okay, so that is cerclage. We call it cerclage or encerclage. Okay, now there are two types of cerclage. One is transvaginal and the other one is transabdominal cerclage. Okay, now transvaginal is a type of cerclage which is usually applied during pregnancy. Okay, not in the pre-pregnant period but during pregnancy for a pregnant woman. Okay, and under this we have three varieties. One is McDonald, the second is Shirodkar, and the third is Worms suture. Okay, McDonald, Shirodkar and Worms suture, out of which the most commonly performed one is McDonald. Okay, so McDonald is commonly known as purse string suture. Okay, McDonald is commonly known as purse string suture. Okay, fine. So this is the most common. McDonald is the most common one. Okay, so if not McDonald, the second most common is Shirodkar. Shirodkar is technically difficult to apply. Shirodkar. In Shirodkar, usually what we do is we apply the suture at the level of internal os, which is high in position when compared to McDonald's. Okay, so for this reason, the Shirodkar is technically difficult and also much effective. So wherever McDonald fails, you can try Shirodkar. That's how it is. Okay, so Shirodkar is more effective than McDonald. Okay, McDonald is simple to apply. Okay, McDonald is simple to apply, but McDonald is not as effective as Shirodkar. Shirodkar is more effective but technically more difficult. Okay, what is worm suture? Worm suture is used in emergency situations. Okay, worm suture is used in emergency situations where the patient comes with open cervix with, say, ballooning. Okay, so how do we apply this worm suture? Like, say this is the cervix. Okay, if this is the cervix and say this is the 12 o'clock position, 3 o'clock, 6 o'clock and 9 o'clock. Okay, so if the cervix is like this, worm suture is where we apply one stitch like this connecting 6 and 12. Okay, one stitch connecting 6 and 12 and put a knot here, and we apply another stitch like this connecting 3 and 9. Okay, so one stitch connecting 6 and 12, another stitch connecting 3 and 9 clock positions. Okay, so this is worms. Okay, worms stitch. Okay, so this stitch is usually applied in emergency situations where the process of preterm labor has already set in. Okay, so these are transvaginal procedures. We have transabdominal procedures here. Transabdominal procedures are usually applied before pregnancy when the woman is planning for pregnancy. Okay, so in the pre-pregnant period. Okay, we have two types here. One is laparoscopic cerclage and the other one is lash procedure. Laparoscopic and lash procedure. Okay, so in fact laparoscopic procedure can be applied both during pregnancy as well as in the pre-pregnant state, whereas lash procedure is exclusively used only for non-pregnant women. Okay, in the pre-pregnant period. Okay, lash is used only for non-pregnant women. Okay, and also remember, since I have told you about two procedures, one transvaginal and the other one is transabdominal. Transvaginal stitch is supposed to be removed at 37 completed weeks, because transvaginal stitch is one stitch where you can allow vaginal delivery. Okay, whereas transabdominal stitch, like whatever I told you, the lash procedure or the laparoscopic procedure, whenever you apply transabdominally, please remember that it is permanent. Okay, it is permanent. You're not going to remove it, rather you're going to do cesarean section to deliver the baby. Okay, so say in case the woman is a primigravid woman, or this woman does not have any live children and she's going to have she's going to go through few more pregnancies, like say 2 or 3 pregnancies, and you need a permanent procedure in order to avoid repeated sutures being applied in her successive pregnancies, you can apply this lash stitch. You understand? So this lash stitch will stay in situ, and you can deliver the baby by cesarean section so that it stays in situ for her successive pregnancies as well. Okay, so this is lash procedure. Okay, so this should be removed at 37 completed weeks. Which one? The transvaginal suture either the McDonald's suture or the Shirodkar or the worm suture, whatever, it should be removed at 37 completed weeks, and the woman can be allowed to deliver vaginally. Whereas in trans-abdominal sutures like lash suture, it's going to be permanent and you're going to deliver only by cesarean section, and it need not be removed. That's the take-home point. So here the question is like this: the cerclage procedure that is done for a non-pregnant woman is lash. So we have the next question here. Identify the false statement regarding pathogenesis of pre-eclampsia. We have a set of markers here. We have endothelin, we have soluble FMs like tyrosine kinase. SFLT is soluble. For those of you who do not know this, soluble FMs like tyrosine kinase. Soluble FMs like tyrosine kinase 1. Okay. PIGF is placental growth factor. Okay. PIGF is placental growth factor. Placental growth factor. Okay. Endothelin and soluble FMs like tyrosine kinase are anti-angiogenic factors. Okay. Please remember these two, endothelin and soluble FMs like tyrosine kinase, are anti-angiogenic. They are anti-angiogenic. Okay. So what will happen to these factors in preeclampsia? Preeclampsia is basically because of vasospasm and increase in markers which are anti-angiogenic, right? So these factors will increase. Okay. These factors will increase. Okay. Now placental growth factor is angiogenic. So obviously placental growth factor will decrease. Okay. So all angiogenic factors will decrease, all anti-angiogenic factors will increase. That is what is usually happening in preeclampsia. Okay. So there is no new vessel formation, the existing vessel undergoes spasm, and there is no proper blood supply to the baby develops IUGR. Okay. So this is what is happening. Now this is PGI2 and this is thromboxane A2. Okay, we usually calculate this ratio between PGI2 and thromboxane A2. Now out of these two, tell me which is a vasodilator and which is a vasoconstrictor. PGI2 is a vasodilator. Okay, PGI2 is a vasodilator, thromboxane A2 is a vasoconstrictor. Okay, so what will happen? PGI2 will decrease and thromboxane A2 will increase. Vasoconstrictor molecules will increase, leading to vasospasm and preeclampsia. But here the answer says PGI2 thromboxane A2 ratio increases. So if this is what is happening in preeclampsia, the ratio should decrease, no? The ratio will not increase. Okay. So this ratio, PGI2 thromboxane A2 ratio, PGI2 thromboxane A2 ratio, this will decrease in preeclampsia, this will not increase. Okay. Nitric oxide decreases. Yes, nitric oxide is a vasodilator and this will decrease, resulting in vasospasm. Okay. So which one is the wrong statement here? The wrong statement is C. Okay. PGI2 thromboxane A2 ratio decreases in preeclampsia. Okay. See this chart. Okay. Markers in preeclampsia. Okay. So for completion's sake, I have put a table where I am showing the markers that increase with preeclampsia and those markers which decrease with preeclampsia. So here there are certain markers which increase with preeclampsia, and they are theca lutensis, growth hormone, soluble FMs like tyrosine kinase, leptin, endothelin, soluble endoglin, cardiac troponin, D-dimer, consumption of factor 8, fibrinopeptides, inhibin activin uric acid, BNP and ANP. Okay, brain natriuretic peptide and atrial natriuretic peptide. Okay, so these are markers which increase with preeclampsia, and there are certain markers which decrease with preeclampsia. They are PGI2, refractoriness to angiotensin, nitric oxide, VEGF and PLG. As I already told you, this is placental growth factor. Okay, so this is PGI2, prostaglandin I2, this is placental growth factor. Okay, so these are factors which decrease with preeclampsia. Okay, these are substances which decrease with preeclampsia. Okay, so we'll move on to the next question. The next question again is about preeclampsia. We have a question on magnesium sulfate here. Okay, so which of the following is false about magnesium sulfate in preeclampsia? Okay, so first I'll tell you something about magnesium sulfate and then we'll get back to the question. Okay, what is magnesium sulfate? Magnesium sulfate is an anticonvulsant drug. Okay, magnesium sulfate is an anticonvulsant drug. Okay, this is the anticonvulsant drug that we use during pregnancy. Anticonvulsant drug that we use during pregnancy. Okay, to treat preeclampsia and eclampsia. Okay. So, what is the regimen used here? The name of the regimen is Pritchard regimen. Okay, the name of the regimen is Pritchard regimen. So, we have loading and maintenance dose in this Pritchard regimen. Loading dose consists of administering 14 gram of magnesium sulfate. 14 gram of magnesium sulfate, which is divided into 4 gram of IV infusion diluted to 20% and 10 gram of IM injection as a 50% solution. Okay, I am repeating this point. Pritchard regimen consists of loading and maintenance dose. Loading dose is where we give 14 gram of magnesium sulfate, okay, partly as IV and partly as IM. Okay, so we take 4 gram of magnesium sulfate and dilute it to 20% and give it as IV infusion as a part of loading dose. The remaining 10 gram of this 14 gram will be given as a 50% solution in the buttock as dose. Maintenance dose is infused at the rate of 1 gram per hour. Okay, 1 gram per hour infusion is the maintenance dose. Okay, so previously we were giving maintenance as IM injections of 5 gram every 4th hourly, but now we've given off IM injection. What we're giving is IV infusion at the rate of 1 gram per hour. Okay, so this is about loading and the maintenance dose. So for how long will you give magnesium sulfate? See, you will have to start magnesium sulfate as soon as you diagnose severe preeclampsia. You will not wait for the woman to throw a fit to start magnesium sulfate. You got my point. Okay, you will have to start it well in advance. So magnesium sulfate can either be used for prophylactic purpose or for therapeutic purpose. Okay, so it can be used for both prophylactic as well as therapeutic purposes. Okay, so you will start as soon as you think that she is about to throw a fit. If the woman has, you know, features of severe preeclampsia, or if she has imminent symptoms like headache, vomiting, blurring of vision, epigastric pain and all those, or if she's already thrown a fit, you will start magnesium sulfate at the first point of contact. Okay, and from then on you will give loading dose and you will keep the patient on maintenance dose of 1 gram per hour infusion. Okay, now when will you stop? You will continue to give the drug until she delivers and 24 hours from the point of delivery. Okay, so 24 hours thereafter you have to continue. Or if she develops any seizures after delivery, okay, in case she develops any seizures after delivery, you will have to continue the drug, I mean the maintenance dose, you will have to continue it for 24 hours from the point of last fit. You understand? So 24 hours from delivery or 24 hours from the last seizure, whichever is later. Okay, so this is about how to give and when to stop magnesium sulfate. We have few more MCQs in magnesium sulfate. What is the mechanism of action of magnesium sulfate? It blocks calcium channels. That is the most important mechanism of action. It blocks calcium channel. It also has NMDA blocking property. Okay, it is also an NMDA blocker. So magnesium sulfate is not a safe drug. It has a very narrow therapeutic index. So you need to monitor the woman with certain parameters, and they are urine output, knee jerk and respiratory rate. Okay, so urine output should at least be 30 ml per hour. Okay, so 30 ml per hour. Knee jerk or any other deep tendon reflex in the body should be present. Okay, and the respiratory rate should at least be 14 per minute. Now, why do we monitor with these parameters? We monitor with urine output because magnesium is excreted unchanged in the urine. Okay, magnesium is excreted unchanged in the urine, and that is why we load the patient with so much of magnesium sulfate, like say 14 gram for the loading dose and 1 gram per hour for the maintenance dose, because half of what you administer will be excreted through the kidneys very soon before it reaches the therapeutic serum concentration. Okay, it is important to monitor the patient's urine output, because any compromise in the kidney function, okay, any compromise in the kidney function will lead to magnesium sulfate toxicity. So just because we are monitoring with urine output, please do not mistake that magnesium harms the kidney. It is not like that, okay. It is the compromise in the renal function that leads to magnesium sulfate toxicity and not vice versa, okay. So the urine output should at least be 30 ml per hour to, you know, ensure that the magnesium is getting excreted at a constant rate, okay. So knee jerk should be present because this is this drug, you know, it is a muscle relaxant, okay. Magnesium is a muscle relaxant, so yes, all the deep tendon reflexes would disappear in case of toxicity, okay. And it also is a it causes respiratory depression, okay. So the respiratory rate should at least be 14 per minute, okay. This is how we will monitor. Next we will move on to the therapeutic level. What is the normal serum therapeutic level? Serum therapeutic level is 4 to 7 milliequivalents per liter. The toxic level is 10 milliequivalents per liter, and that is when first sign of toxicity appears, okay. So what is the first sign of toxicity? Loss of knee jerk is the first sign of toxicity, and this appears at 10 milliequivalents per liter, okay. Loss of knee jerk or loss of deep tendon reflex is the first sign of toxicity, which is seen at 10 milliequivalents per liter, and thereafter the patient might develop respiratory depression and respiratory arrest when it reaches 12 milliequivalents per liter, okay. So loss of knee jerk at 10 milliequivalents per liter and respiratory depression and 12 milliequivalents per liter is the most important signs of toxicity of magnesium sulfate, okay. So if the patient has developed any sign of toxicity, what would you do? What would you do? Yes, you have to immediately stop the infusion and give her an antidote, which is nothing but calcium gluconate, okay. The antidote for magnesium sulfate is calcium gluconate, and there is something called rule of 10 here. What is rule of 10? This calcium gluconate is given as a 10% solution, 10 ml IV over 10 minutes, okay. 10 ml of 10% solution IV over 10 minutes is rule of 10 for calcium gluconate, okay. So what are the other clinical features or other uses of magnesium sulfate? Is it only an anticonvulsant drug? No, it also has other benefits. It is a neuroprotective drug, it is a tocolytic drug, okay. So it is a neuroprotective drug. What does neuroprotective drug mean? What does it do? It prevents neonatal seizures, okay. It decreases the incidence of cerebral palsy. So we use it for all preterm deliveries. We give it to the mother in order to protect the baby from developing cerebral palsy. You understand my point? If any lady develops preterm labor, before the lady delivers the baby, you will start the woman on magnesium sulfate so that the baby gets magnesium sulfate in utero, and this will, you know, protect the baby from neonatal seizures. It will also protect the baby from developing cerebral palsy in the newborn period, okay. So this is a neuroprotective drug. It is also a tocolytic drug because I told you it is a muscle relaxant. It relaxes the smooth muscle of the uterus, okay. It is a tocolytic drug, but please remember, this tocolytic action is not seen in the usual dose that we give for convulsions, okay. So for tocolytic action, the dose is little high, okay. So this action is dose dependent. That means more the drug you give, more the tocolytic activity. That's how it is, okay. So tocolytic activity is not seen in the usual dose that we give to treat seizures, okay. So this is it. And also please remember, I already told you, in case of renal failure, magnesium sulfate toxicity would appear, and there needs a little dose adjustment in women with renal failure. So how do we adjust the dose? Do we adjust the loading dose here? No, we don't, okay. We don't adjust the loading dose, rather we only adjust the maintenance dose, okay. So maintenance dose should be decreased. Maintenance dose should be decreased in women with renal failure and not the loading dose, okay. So hope you all had some knowledge on magnesium sulfate. Now we'll get back to the question, okay. So see the question here. Which of the following is false about magnesium sulfate in pre-eclampsia? It is given to treat both eclamptic seizures and hypertension simultaneously. Is it an antihypertensive drug? No, it is not, okay. It is not an antihypertensive drug. It is only an anticonvulsant. It is not an antihypertensive. Only the maintenance infusion rate should be altered with diminished GFR and not the loading dose. This is absolutely correct, and I just told you that loading dose should not be altered in case of renal failure. It's only the maintenance dose that should be altered. Inhibition of uterine contractility is dose dependent. This again is true. And magnesium sulfate is discontinued 24 hours after delivery or 24 hours after the last seizure, whichever is later. This again is correct. Okay, so the wrong option is option A. Okay, find the next question here. Woman has been taking tamoxifen for breast cancer, now wants to conceive. How many days after stopping tamoxifen can she conceive? Again, this is a very tough question. Okay, this is a very tough question. So, for those who are good at guessing, you must have guessed the answer as 3 months, right? For those who are good at guessing, you must have guessed the answer is 3 months, no? Yes? Okay. So, yes, the answer is 3 months here. Okay. So, how long should you wait to conceive after taking tamoxifen or after stopping tamoxifen? 3 months. Okay. So, the textbook of obstetrics, Williams textbook of obstetrics says there has to be at least a gap of 2 months from stopping the drug, okay, to pregnancy. So, 2 months, it should at least be 2 months, but among the given options, 3 months is a better answer. Okay, so what does it do? Is it a teratogenic drug? Yes, tamoxifen is a teratogenic drug. What group of drug it is? Tamoxifen is a selective estrogen receptor modulator. Okay, tamoxifen is a SERM, selective estrogen receptor modulator, and we use tamoxifen to treat breast cancer. Okay, we use tamoxifen to treat breast cancer. Tamoxifen can also be used for ovulation induction, like how we use clomiphene. We can also use tamoxifen for ovulation induction. Okay, so when the fetus gets exposed to tamoxifen, what does it do? Tamoxifen, yes, there was a drug called diethylstilbestrol, DES, diethylstilbestrol, okay. This again is a teratogenic drug, okay. If you're not using this drug during pregnancy now, because this diethylstilbestrol leads to certain anomalies, the most important of which is adenocarcinoma of the vagina. Adenocarcinoma of the vagina, and not only this, it also leads to adenocarcinoma of the cervix, okay. And it doesn't stop here, it leads to certain anomalies like say T-shaped uterus, okay, coxcomb cervix, okay, basically uterine anomalies, okay. There are many uterine anomalies that are associated with diethylstilbestrol. So, it is a teratogenic drug, So, what does tamoxifen do? Tamoxifen again, when exposed, when used during pregnancy, tamoxifen again leads to a DES-like syndrome in the baby, okay. Because of which this drug should not be used during pregnancy, and in case the woman is exposed to tamoxifen or she's been taking tamoxifen for any reason, like say breast cancer, there has to be at least a 3 months gap between the stoppage of drug and pregnancy, okay. So, this is it. So, we'll move on to the next question here. 37-year-old nulliparous woman who's having regular intercourse is on COC, combined oral contraceptive. What is your ideal advice to her? Her mother had breast cancer at the age of 55 and her sister had ovarian cancer at the age of 40. So, it's a very nice combo, no? Breast cancer and ovarian cancer, okay? CA breast and CA ovary. Come on, give me one syndrome where CA breast and CA ovary coexist. Yes, you're right. BRCA, right? So, BRCA is one genetic abnormality where breast cancers and ovarian cancers are frequently seen. Okay, so we have two types here, BRCA1 and BRCA2. BRCA1 is related to chromosome 17 and BRCA2 is related to chromosome 13. Okay, so which malignancy is more common in BRCA1 and 2? Is it breast cancer or ovarian cancer? Yes, breast cancer, right, breast cancer. Okay, so BRCA1 is more dangerous than BRCA2. The incidence of breast cancer with BRCA1 and BRCA2 are 60% and 50% respectively, and the incidence of ovarian cancer with BRCA1 and 2 are 40% and 20% respectively. Okay, so from this data you understand that BRCA1 is more dangerous than BRCA2. Now, 60% and 40% are two important values. I mean, I'm giving the rough figures here, okay. So the approximate figures, okay, anything which is close to this number can be picked as the answer. Okay, so 60% and 40% for BRCA1 for breast cancer and ovarian cancer respectively. Okay, so what should you do? Any woman coming with a family history of breast cancer or ovarian cancer or a combination of this, okay, especially with close relatives like say the mother or the sister, okay, yes, she has to be subjected for BRCA screening, and if found positive, she has to undergo a prophylactic bilateral salpingo-oophorectomy at the age of 35 to 40 for BRCA1 and 40 to 45 for BRCA2. Okay, so as soon as she completes family, she has to undergo this bilateral salpingo-oophorectomy. Okay, and until she finishes her family, until she completes her family, she has to get annual mammography or MRI for the breast to rule out breast cancer, and clinical examination every 6 to 12 monthly. Okay, so this is what is about BRCA 1 and 2. So here there is a significant family history related to BRCA abnormality, and this lady is definitely a candidate for BRCA gene testing. Okay, fine. So we'll move on to the next question here. As per WHO SAGE guideline, the recommended dosage on HPV vaccine in 9 to 14-year-old girl is. This again is a very tough question, because the question appears easy but it is tough. You know why? Because this WHO SAGE guideline, is a very recent guideline that was introduced by WHO only the recent few months back. Okay, so the answer, before I tell you the answer, I'll tell you what this vaccine is all about, and I'll tell you the old recommendation by WHO. Okay, so this vaccine is against HPV, human papilloma virus, and the most common strain, human papilloma virus strain, is 16. Okay, we have around 120 subtypes in HPV, out of which we have 40 subtypes infecting the lower genital tract, out of which 15 subtypes are oncogenic varieties. Okay, so among the oncogenic varieties, 16 and 18 are the most important ones, out of which 16 is the most common one and 18 is the most virulent one. Okay, 16 leads to squamous cell cancer, 16 more commonly leads to squamous cell cancer, and 18 more commonly leads to adenocarcinoma. Okay, so we have vaccines. We have 3 types of vaccines against HPV, and they are Cervarix, Gardasil 4 and Gardasil 9. Out of which Cervarix is almost out of the market. We are not using Cervarix now because Cervarix is a very primitive one, and Cervarix includes only 2 strains of HPV. Gardasil 4 includes 4 strains of HPV, and Gardasil 9 includes 9 strains of HPV, and we call these vaccines as bivalent, quadrivalent, and nanovalent, depending on the number of strains that are included in the vaccine. Bivalent is Cervarix, which includes 2 strains, quadrivalent is Gardasil, which includes 4 strains, and nanovalent is Gardasil 9, which includes 9 strains. Okay, so what are the strains included in these vaccines? Cervarix includes only 16 and 18. Okay, Gardasil includes 6, 11, 16 and 18. Gardasil 9 includes 31, 33, 45, 52 and 58, along with 6, 11, 16 and 18. Okay, so Gardasil 9 includes 9 strains, which again is a very repeated question. This question has already been asked in AIMS exam. Okay, so this is this is all about the types of vaccine. Okay, now what does this vaccine contain? This vaccine contains L1 protein. Okay, this L1 is a viral protein which which is used, basically vaccine is against this L1 protein of the HPV virus. Okay, this again is an AIMS question. This question was there in I think 2020 AIMS exam, 2020 or 2021 AIMS exam. Okay, so when should this be administered? The ideal age group is 11 to 12 years. The ideal age group is 11 to 12 years, and it protects against so many diseases, not only cervical cancer. Okay, it offers protection against vulval cancer, vaginal cancer, basically all HPV related cancers in the body, okay. So CA vulva, CA vagina, okay, oral cancer, oropharyngeal cancer, okay, oropharyngeal cancer, anal cancer, okay, anal cancer, okay, CA larynx, all HPV related malignancies, okay. And last but not the least, CA cervix also. All these malignancies are protected by cancers, HPV vaccine, okay. Number of doses, the last important point is the number of doses, okay. So the previous guideline said if the age is less than 15 years, then 2 doses are adequate, okay. And if the age is more than 15 years, 3 doses are required. This was the old guideline, okay. If the age is less than 15 years, 2 doses are adequate, and if the age of the girl child is more than 15 years, not only girl child, it can also be used for men, okay. So if the age of the child is more than 15 years, 3 doses are required, okay. Now there is a recent guideline that is proposed by WHO called WHO SAGE guideline, and this WHO SAGE guideline says if the age is less than 15 years, 1 or 2 doses, 1 or 2 doses, okay, can be given, okay. So this is a very critical one, right? So so because that option was there, 1 or 2 in the question, we'll be forced to pick this one only, okay. I'm not sure what the options were. According to students recall, the options were like 1 or 2, 2 and 3, okay. So if this was the option that you had, and if there was an option called 1 or 2, then that is the most appropriate answer. If this option was not there, then I would recommend you all to go for 2. You understand, no? Yes. So the most appropriate answer is 1 or 2. And the second most appropriate answer will be 2, okay. So we had one other question from HPV. So please remember, we are getting questions from cervical cancer almost in every other INI CET exam, okay. So there is no question paper without a question on cervical cancer, because cervical cancer is the most common genital malignancy, the most common genital malignancy among women, Indian women, and not the most common malignancy. Breast cancer is the most common malignancy worldwide, okay. Also in India, breast cancer is the most common malignancy among women, but the most common pelvic malignancy is cervical cancer. And of course, cervical cancer is preventable, okay. Because it is a preventable cancer, it is important to know about these vaccines in detail, okay. We had one other question from HPV here. Which of the following is not caused by high risk HPV? So I just told you, no, high risk HPV causes only malignancies of the vulva, vagina, cervix, oropharynx, larynx and the anus, okay. So this is what high risk HPV causes, okay. This is what high risk HPV causes, okay. So the odd man here is laryngeal papillomatosis, okay. The odd man is laryngeal papillomatosis. Laryngeal papillomatosis is caused by low risk HPV, okay, HPV 6 and 11, low risk HPV and not high risk HPV, okay. So this is it, okay. So we'll move on to the next question here. Vas deferens and seminal vesicles are absent in, okay. This is a very simple and straightforward question. I'm not going to discuss anything further here, and the answer is cystic fibrosis, and this condition CBAVD is commonly seen with cystic fibrosis. So what is CBAVD? Congenital bilateral absence of vas deferens. Congenital bilateral absence of vas deferens, CBAVD, is commonly associated with cystic fibrosis, wherein you have mutations in CFTR genes, right? So this is a simple and a straightforward question. Okay, the next question here is the most common feature associated with Kallmann syndrome. Again, this is a very easy and a very straightforward question, simple question. The answer is anosmia. No. So I think all of you all must have marked it right. We'll discuss few more points about Kallmann syndrome. What is Kallmann syndrome? Kallmann syndrome is failure of both olfactory axonal and GnRH neuronal migration from the olfactory plug cord. Okay, so it is a problem with migration of the GnRH neurons, okay, migration of the GnRH neurons. So what is the mode of inheritance? The most common mode of inheritance is X-linked, okay, the most common mode of inheritance is X-linked. But remember, it can also follow autosomal dominant or autosomal recessive mode of inheritance, okay. So what are the clinical features here? The clinical features are amenorrhea, most common is amenorrhea, sexual infantilism, and then comes anosmia. So this is the usual triad, okay, amenorrhea, sexual infantilism and anosmia. But yes, remember, it can also be associated with color blindness, midline facial defects like cleft lip and all, sensory neural hearing loss, renal anomalies, syndactyly and synkinesis. Okay, so these are certain features which can be seen at times, but more often what you see is amenorrhea, sexual infantilism and anosmia. Okay, so it is not precocious puberty, it is actually sexual infantilism that is seen in Kallmann syndrome. Okay, so next question here, this again is a very easy question. Place the following in the correct order in the seminiferous tubules. Okay, so we have various combinations of spermatogonia, primary, secondary spermatocyte, spermatozoa and spermatid. So this again is an easy question. This is an embryology question, but still we will discuss here. Everything starts with spermatogonia, right? Spermatogonia is a diploid cell. Spermatogonia is a diploid cell. So what is the karyotype of spermatogonia? It is 46XY. 46XY, it's a diploid cell, and that becomes primary spermatocyte, which again is a diploid cell. Okay, so primary spermatocyte is a diploid cell, and then comes first meiotic division. So meiotic division is the actual reduction division. So from now on we will be forming haploid cells. So this primary spermatocyte being a diploid cell, it divides into two secondary spermatocytes, one with 23X and the other one with 23Y, okay, 23X and 23Y. So you form two haploid cells as a result of first meiotic division, okay. Then comes second meiotic division, okay. So second meiotic division is like mitotic division, where the daughter cells will have the same number of chromosomes as the parent cell. So here again it's 23X or 23Y, and as a result of this second meiotic division we form spermatids, okay. So these spermatids can either be of 23X type or be of 23Y type, okay. Now this spermatid undergoes a process of spermiogenesis, okay. These spermatids, they undergo a process of spermiogenesis to form the final cell called spermatozoa, okay. So what is the correct order? The correct order is spermatogonia followed by primary spermatocyte, secondary spermatocyte, spermatids and finally spermatozoa. So this is the correct answer. Okay. So next there is a very easy and a very logical question. I think you all must have answered this question. This has been discussed several times, no? This has been discussed several times under infertility, under amenorrhea and so many other topics. Yes, so it deals with what? Hypogonadotropic hypogonadism. Okay, so hypogonadotropic hypogonadism means what? Whenever we evaluate male infertility, there are three hormones that we should check to, kind of find out the site of lesion. So it can either be a testicular cause of infertility, male infertility, or it can be hypothalamic cause of male infertility, or pituitary cause of male infertility, or it can be obstructive cause of male infertility like obstructive azoospermia. It can be an obstruction at the level of vas deferens or the epididymis or the seminal vesicles. Yes, so there are certain types of oligospermia. So depending on the site of lesion, the hormonal changes would reflect the site of lesion. Okay, so basically three hormones are there which we would check, and they are FSH, LH and testosterone. So if it is a pituitary problem, if the site of lesion is pituitary or hypothalamus, what would happen to FSH? FSH would decrease, LH would decrease and testosterone would also decrease. So all these hormones will decrease in case of pituitary or hypothalamic azoospermia or oligospermia, and we call it what? Hypogonadotropic hypogonadism. Hypogonadotropic, why? Because gonadotropins are less. Okay, FSH and LH are the gonadotropins and they are less. Okay, next is testicular failure. So testicular failure, testis is where testosterone is produced, and this testosterone gives feedback, negative feedback signals to the pituitary and hypothalamus. So whenever the testosterone is high, FSH will be low. Whenever the testosterone is low, FSH will be high. That's how it is, no? So, in case of testicular failure, testosterone will be low. Okay, in case of testicular failure, testosterone will be low. What will happen to FSH and LH? FSH and LH will increase. Okay, FSH and LH will increase because the gonadotropins increase here. We call this condition as hypergonadotropic hypogonadism. And in obstructive azoospermia, obstruction is purely mechanical and it is not hormonal. So, all the hormones will remain normal. Okay, in obstructive azoospermia, all the hormones will remain normal and we call this condition as what? Eugonadotropic hypogonadism. Okay, this is called eugonadotropic hypogonadism because all the gonadotropins remain normal. Okay, so it is as simple as that. Hypogonadotropic. The question is on hypogonadotropic. So hypo means what? Low FSH, low LH. Hypogonadotropic. Okay, low FSH, low LH, low testosterone again and oligospermia. Okay, so which is the correct answer? A, B, D. Okay, A, B, D. This is the correct answer. Okay. So, next question is on diabetes, which is incorrect regarding diabetes in pregnancy. Okay, I mean, even if you do not know how to manage labor during, labor in women with diabetes, you can very well answer this question because the options are, 3 out of 4 options are a little difficult, but one option is very easy and that is the answer. Okay, so anyway, we'll read the options now. Elective LSES does not decrease the incidence of brachial plexus injury. See, we will not do, in fact, cesarean section is not the mode of delivery, preferred mode of delivery for women with diabetes. Okay, vaginal delivery is the preferred mode of delivery for women with diabetes. Okay, we do cesarean section only for obstetric indications. You understand? We do cesarean only for obstetric indications. Okay, of course, diabetic pregnancies are at risk for brachial plexus injury, but that doesn't mean that all diabetic pregnancies should be delivered by cesarean section. Okay, so whenever there is macrosomia, whenever the baby weighs more than 4 to 4.5 kg, there only you deliver by cesarean section and not for all. Okay, so this option can be taken as the correct statement. Okay, in active labor, if the RBS random blood sugar is less than 70 milligram percent, 5% dextrose is started. That's correct. That's correct. Okay, so how do we manage labor in diabetic pregnancies? You will give the night dose of insulin and you will skip the morning dose of insulin. Okay, so this is not only applicable for diabetic women in labor, but for any other surgery on a diabetic patient for that matter. Okay, so whenever you operate on a diabetic patient or whenever you do any procedure, elective procedure for a diabetic patient, you will give the night dose of insulin and you will skip the morning dose of insulin because the insulin control will be done on the theatre, on the table, or when the woman is in labor in the labor room. Okay, and the insulin will be given according to what she requires, and the most commonly used insulin here is either a short acting or an ultra short acting insulin, and preferably in the infusion form. Okay, so the routine morning dose of insulin will not be used for any patient who is posted for surgery, elective surgery, who is on insulin therapy. Okay, and hourly CBG monitoring should be done for diabetic woman on labor with normal saline infusion. Okay, so she'll be started on normal saline first. So when will you give dextrose then? If she requires dextrose solution, that means if the CBG is less than 70 milligrams percent, you will start her on 5% dextrose. Okay, and if the CBG is more than 100 milligrams percent, along with normal saline, you will give insulin at the rate of 1.25 units per hour. You understand? So if the sugar is more than 100, start insulin. If the sugar is less than 70, start dextrose, or otherwise give only NS, normal saline. Okay. In active labor, if the RBS is less than 70 milligrams percent, 5% dextrose is started. This is a correct statement. Both the night and the morning dose of insulin are given in a patient being planned for induction of labor. This is a wrong statement. Okay, only the night dose is given, not the morning dose. Capillary blood glucose levels are maintained at 95 fasting and 122 hours postprandial. This is correct for any woman who is on meal plan therapy. The target will be fasting less than 95, 1 hour postprandial less than 140, and the second hour postprandial less than 120. This is the target for any woman who is on treatment for diabetes during pregnancy. So next question is on clotting factor. Which of the following clotting factor does not increase with pregnancy? Because I have discussed this several times, I am not discussing it here. I'll tell you a few points in a nutshell, okay. So all clotting factor, pregnancy first of all is a prothrombotic state, okay. Pregnancy is a prothrombotic state. Pregnancy is a prothrombotic state. Why? Because all clotting factors increase during pregnancy except two clotting factors, and they are 11 and 13. Clotting factor number 11 and clotting factor number 13 are the two clotting factors which either remain normal or decrease with pregnancy but never increase, okay. So factor 11 does not increase with pregnancy, okay. And also remember, along with this, there are certain clotting factors which increase much more than the other clotting factors, the most important of which is fibrinogen, okay. Almost 100% increase in fibrinogen is seen during pregnancy, okay. Next is clot lysing. We have a clot lysing mechanism, no? We have a protein called plasminogen which is converted to plasmin and the activating substance is plasminogen activator, okay. Now what happens to this fibrinolytic system? This fibrinolytic system is depressed during pregnancy, okay. This fibrinolytic system is depressed during pregnancy, because of which there is increased clot formation and there are high chances for deep vein thrombosis, pulmonary embolism, and infarct wherever possible, okay. Because of this, yes, pregnancy is a prothrombotic state, and of course DVT can develop in both the limbs, but left-sided DVT is more common than right-sided DVT, okay. So left-sided DVT is more common than right-sided DVT. So these are the points you have to remember under this topic, okay. But one point I want you to know, regardless of all these changes, please remember bleeding time and clotting time remain unchanged with pregnancy, okay. Bleeding time and clotting time remain unchanged with pregnancy. So the next question is here, which is incorrect regarding innervation of the uterus, okay. Incorrect regarding innervation of the uterus, okay. So you should know these points to answer this question. Basically that is an easy question, answerable one. Pain during labor, okay. So where does it go from? Pain during labor, in the first stage of labor, pain is mainly from the uterus, okay. In the first stage of labor, first stage is where the cervix is dilating, no. Second stage is where the cervix is already dilated and the baby is about to deliver, no. So first stage is from onset of true labor pain to full cervical dilatation. The second stage is from full cervical dilatation to delivery of the baby, okay. So first stage of labor, the pain is mainly from the uterus, whereas in the second stage of labor, the pain is mainly from the lower vagina and the perineum. What are those fibers which carry the uterine pain? Uterine pain is carried by T10 to L1, okay. Uterine pain is carried by T10 to L1, okay. Cervix and upper vaginal pain are carried by S234 and lower vaginal pain are carried by pudendal nerve. So the pudendal block that you give to do any procedure in the perineum usually relieves only the lower vaginal pain, okay, not anything above that, okay. So just see this question. In early labor, pain is from the uterus. This is correct. Motor innervation of the uterus is at the level of T7-8. This is wrong. Okay. T10 to L1 is the correct answer. Sensory visceral supply of the uterus, cervix and the upper vagina is to the Frankenhauser plexus. This is correct. Second stage of labor, pain is mainly from the lower vagina. This is again correct. Okay. So match the histopathological feature with the appropriate tumor. Okay, so we have some tumors and their histological features here. This again is a very famous question, and almost every question paper has this question, and we've discussed in our DocTutorials app, in our DocTutorials revision programs, in our QRPs, and in our tested discussion series, and almost all the sessions that we have discussed, we have one question from this. Yes, so almost around 8 to 10 times I have discussed these questions. So, but then for completion's sake, yes, I will tell you So what is the histological feature in serous cystadenoma? The histological feature in serous cystadenoma is psammoma body. In mucinous cystadenoma, it is pseudomyxoma peritoni. Clear cell cancer, it is hobnail cell. Brenner tumor, Walthat cell nest. Dysgerminoma, lymphocytic infiltration. Teratoma, Rokitansky protuberance. Endodermal sinus tumor, Schiller dual bodies. Granulosa cell tumor, Kohl-Exner bodies and coffee bean nuclei. Hyles cell tumor, Rinke crystals. Okay, so this is one must read topic. Okay, this is one must read topic. You should know all of these, or else if making a mistake here is a blunder. Okay, so making a mistake in repeat is definitely a blunder. So you should know this. This is one repeated question. It comes almost in almost every INI, CET and NEET. How does it go here? Schiller dual body, yolk sac, psammoma body, serous cystadenoma, lymphocytic infiltration, dysgerminoma, and hair tooth cartilage bone, teratoma. Okay, so teratoma is where we have cells from all the three cell lines, endoderm, mesoderm and ectoderm, no? So, this is it, okay, fine. Yeah, next question is on modified biophysical profile, okay. What is biophysical profile? Biophysical profile is all otherwise called as Manning score, okay. Biophysical profile is otherwise called as Manning score. Manning score, okay. So, the actual biophysical profile has 5 components, okay. What are they? Number 1 is non-stress test. Non-stress test. Number 2 is amniotic fluid volume, not amniotic fluid index, okay. Amniotic fluid volume measured in terms of single deepest pocket. Single deepest pocket, okay. Amniotic fluid volume measured in terms of single deepest pocket. Next is fetal tone. Next is fetal breathing movement, and the last is gross body movement. Okay, so we have 5 important parameters or components under biophysical profile: NST, single deepest pocket, fetal tone, breathing movement, and gross body movement. Usually, this tone, breathing movement, and gross body movement, these are measured using ultrasound. Okay, and it requires monitoring the fetus for half an hour. You keep the probe over the pregnant lady's abdomen for 30 minutes and you just keep watching the screen for some breathing movements or fetal extension, flexion or body movements. It becomes cumbersome for both the sonologist as well as the pregnant woman, right? So, in order to avoid this difficulty, in order to avoid waiting this long for half an hour with the ultrasound machine and the pregnant lady, we've modified this biophysical profile and we've come out with a newer one called modified biophysical profile, which includes only NST and AFI. So, this can be measured instantly. AFI is amniotic fluid index, okay, and that can be taken in minutes instantly. So, you need not make the patient wait in the ultrasound room for half an hour. So, this is the biggest advantage and you get the results quickly and instantly, okay. So, this is modified biophysical profile, modified biophysical profile, okay. So, the question is simple and straightforward. Modified biophysical profile is NST plus AFI, okay, NST plus AFI, okay. This question we will discuss now. Which of the following is true regarding anti-Mullerian hormone? Okay, anti-Mullerian hormone, it decreases the sensitivity of preantral follicles to FSH. That's right. This is a right statement. It is a lipoprotein. That's wrong. Okay, it's a glycoprotein. It is not a lipoprotein. It's a glycoprotein. It correlates with pregnancy outcome in IVF pregnancies. No, this does not correlate with pregnancy outcome. In fact, we usually use it to detect the ovarian reserve. Okay, this is a marker of ovarian reserve. This is not a marker of IVF outcome. It is best tested in the fasting state. Again, this is a wrong statement. Okay, see, this is gonadotropin independent and it does not vary with the day of the menstrual cycle. Okay, like say you measure FSH, LH for evaluation of infertility, you measure it on day 2 only because that keeps changing with the day of the menstrual cycle. But one advantage of AMH is that it decreases gradually over the reproductive years and it does not grossly fluctuate within the menstrual cycle. Okay. So, few more points about anti-Mullerian hormone that you should know. It is also known as anti-Mullerian hormone is also known as Mullerian inhibiting substance or Mullerian inhibiting factor. So, we call it MIF or MIS or AMH, all are just the same. Okay. So, as I already told you, it's a glycoprotein. It's not a lipoprotein. It's a glycoprotein, and it is synthesized by granulosa cell in female. Okay, in the females it is secreted by granulosa cell, and in males by Sertoli cell. Okay, and what does it do in the males? It causes regression of the Mullerian duct, and that is why there is no uterus, fallopian tube and cervix in males. Okay, so it causes regression of the Mullerian duct by 8 weeks and does not allow the Mullerian duct to grow further. So, it is secreted by all types of follicles, including the early primordial follicles. So, it is not only secreted by the developed follicles, but also the follicles which are yet to develop. Okay, but also by the follicles that are yet to develop. Okay, so it is and that is why it does not fluctuate much within the menstrual cycle, because it is secreted even by the resting follicles. Okay, so unaffected by gonadotropins and sex steroids. That's what I told you. It does not vary with the serum FSH levels. It is just independent of FSH, LH and estrogen. It is a marker for ovarian reserve. It is a very, very important MCQ point. It's a marker for ovarian reserve, and in fact this is the best marker for ovarian reserve and can be measured in any day of the menstrual cycle. Okay, it can be measured in any day of the menstrual cycle. So, these are the points you should know about anti-Mullerian hormone. Okay, so next question here. Which of the following is the most teratogenic drug? All given drugs are actually teratogenic, but out of these drugs, if you have to pick one, then the most notorious one is sodium valproate. Okay, sodium valproate is the most teratogenic. Okay, so few points about anti-epileptic drugs in pregnancy. Highest risk is seen with valproate. We have already discussed drugs in obstetrics. Okay, just go to DocTutorials app and watch the video on drugs in obstetrics, where I have mentioned this point. Highest risk among all the anti-epileptic drugs, highest risk is seen with valproate. Okay, other dangerous drugs are carbamazepine, phenytoin, phenobarbital and topiramate. Okay, so what do they usually cause? They cause neural tube defects. So this is one important MCQ point, no? Yes, they cause neural tube defects, and apart from that, facial clefts like cleft lip, cleft palate, cardiac anomalies and low IQ and cognitive disturbances. Okay, so these are few features of anomalies that are seen with teratogenic drugs. Okay, now having understood all these, you should also know which drug is safe during pregnancy. Know which anti-epileptic drug is safe during pregnancy? Yes, levetiracetam and lamotrigine are the two anti-epileptic drugs which are safe during pregnancy. This is another important MCQ point. Okay, levetiracetam and lamotrigine are the two anti-epileptic drugs that are safe during pregnancy. Here is the next question. Which is incorrect regarding postpartum hemorrhage? A blood loss of more than 500 ml in vaginal delivery is PPH. Prolonged labor is a risk factor. Initial management is colloid. If the hematocrit post-delivery is less than the hematocrit at admission, the volume of blood loss can be calculated by adding 500 ml. Okay, this is a very simple question for those who know what is colloid and what is crystalloid. Okay, so blood loss of more than 500 ml in vaginal delivery is definitely PPH. Okay, so what is the definition for PPH? What is the definition for PPH? Blood loss of more than 500 ml in vaginal delivery. Blood loss of more than 1 liter in cesarean section, okay, or more than 1.5 liter in cesarean hysterectomy, okay, that is postpartum hysterectomy, okay, and a loss of or a decrease in hematocrit by more than 10%, decrease in hematocrit. Okay, like say if the woman's hematocrit was 45% before labor, and if it becomes 35 or lesser than that after labor, then that again is postpartum hemorrhage. So this is the definition for postpartum hemorrhage. Okay, blood loss of more than 500 in vaginal delivery, more than 1 liter in C-section, more than 1.5 in cesarean hysterectomy, and a decrease in hematocrit by more than 10%. Okay, so that is a correct one. The option A is correct, and prolonged labor is definitely a risk factor. Prolonged labor, multiparity, there's a huge list of risk factors. No, like prolonged labor definitely is a risk factor, because once the labor is prolonged, the uterus becomes exhausted, uterus doesn't respond to oxytocin anymore and it doesn't contract. Okay, and this again is a definition, accepted definition. Yes, initial management is crystalloid and not colloid. Okay, crystalloid, what we usually give is normal saline. Okay, what we usually give is normal saline, okay, not colloid, okay, to replace the volume first. Okay, so which is true about genetic screening test? Genetic screening test. Okay, what are the genetic screening tests we know, you know of? Like say during pregnancy, what all we do? We have something called first trimester screening, no? Genetic screening test. We have something called first trimester screening. What is this first trimester screening? This first trimester screening is done to rule out aneuploidies in the developing fetus, right? And this first trimester screening is a combination of parameters like maternal age, nuchal translucency, which is an ultrasound marker, nuchal translucency, okay, beta HCG, and pregnancy associated plasma protein A, we call it PAP-A in short. Okay, so we do this first trimester screening between 11 and 14 weeks, to rule out what? To rule out aneuploidies. We do this to rule out aneuploidy, but does it diagnose aneuploidy in the baby? No, it does not diagnose aneuploidy in the baby. It only screens the baby for aneuploidy. That means it is only a screening test. It is not a diagnostic test. It is only a screening test. Okay. In case the woman fails to attend the OPD in the first trimester between 11 and 14 weeks, we have another option which we do between 16 and 18 weeks, and that is triple or quadruple test. Okay. Triple or quadruple test. Okay. So this triple or quadruple test is a serum test. This again is a screening test, and it is just a blood investigation. And when we do what all in this triple or quadruple test? We do maternal serum alpha fetoprotein, beta HCG, okay, and unconjugated estriol, unconjugated E3, okay, and this is triple test. Okay, what is this? This is triple test, and if you combine inhibin with this, it becomes quadruple test. Okay, so this is just a serum test, like how I told you first trimester screening. First trimester screening is also only a blood test. It is a serum test and it is not an invasive test. Okay, and also remember, these tests do not give a diagnosis. They only screen and they only find the probability of this fetus being a Down's baby or any other aneuploid baby. Okay, so just to look at the options here. Most are invasive. No, they are non-invasive serum tests. They are more accurate than diagnostic tests. No, diagnostic test is 100% accurate, whereas these screening tests are only 80 to 90% accurate. They help define the risk of a genetic defect. That is right. Okay, so they only calculate the risk. Okay, they only calculate the risk, and gene mapping is done. That is wrong. Okay, so they help define the risk of a genetic defect. That is correct. We had one question from acute pyelonephritis in this INI CET exam, and this is really a difficult question. So this question is like this: which is incorrect regarding pyelonephritis in pregnancy? Hospitalize the patient, change to oral antibiotics when afebrile, establish the urine output of at least 50 ml per hour with IV crystalloids, and discharge when afebrile for 48 hours, and consider antimicrobial therapy for 5 days. This is really a tough question, and this is because it's a very, not a common topic. So these kind of questions can be expected. 1 or 2 questions of this sort can be expected in all INI CET exams, but please remember, this is not the decision making question, okay, because most of the students, 98 to 99% of the students will not be able to answer these questions. Common questions are the questions which are, the deciding ones, okay. But then, since this question has been asked, We'll learn some points about acute pyelonephritis in pregnancy. First of all pregnant women with acute pyelonephritis should be hospitalized. Okay, all pregnant women with acute pyelonephritis should be hospitalized and they should be subjected for urine culture. Okay, if required, if the patient is very febrile and if the temperature is more than 38 degrees Celsius, blood culture should also be done. Okay, blood culture should be done, and along with it, a blood count, serum creatinine and electrolytes should be done. Okay, the patient's vitals should be monitored, urine output should be monitored, and the urine output should be kept at least 50 ml per hour using IV crystalloid. Okay, so whenever you want to replace the volume and you want a good urine output, crystalloid is the first choice solution, right? So the urine output should be maintained at 50 ml per hour using IV crystalloid. And antibiotics, IV antibiotics should be started. The drug of choice is ampicillin, gentamicin or cefazolin. Okay, either ampicillin, gentamicin or cefazolin or ceftriaxone. So what is the most common organism causing this? The most common organism is E. coli. Okay, most common organism is E. coli, and of course other common organisms, whichever is common in the non-pregnant state is again common here too. Okay, so change to oral antibiotics when afebrile. This is what Williams says, and this question is a direct question from Williams. It has been picked directly from the table that is given in Williams under this heading, acute pyelonephritis. Okay, so change to oral antibiotics when afebrile, discharge when afebrile for 24 hours. Okay, so when the patient is afebrile for 24 hours, she is fit for discharge. Consider antimicrobial therapy for 7 to 10 days. Consider antimicrobial therapy for 7 to 10 days. Okay, so these are the points here. Most of the points that were given were correct except for the last one, and the last, getting back to the question, which is incorrect regarding pyelonephritis in pregnancy. Hospitalize is right. Change to oral antibiotic when afebrile, that again is right. Urine output of at least 50 ml per hour with IV crystalloid is right. Discharge when afebrile for 48 hours is wrong. Discharge when afebrile for 24 hours and consider antimicrobial therapy for 5 days, that is again wrong. The total days of antibiotics will be 7 to 10 days. Okay, so we had another unexpected and tough question this time, which was from lupus nephritis. Okay, lupus nephritis. Okay, so before going into the options, let me tell you some important points about SLE in pregnancy. SLE in pregnancy. What is the incidence of SLE in pregnancy? 1 in 250 pregnancy is the incidence. Okay, 1 in 250 pregnancy is the incidence. And the disease activity improves in 1/3, it remains the same in 1/3, and it worsens in another 1/3. Okay, pregnancy outcome is good if disease has been silent for at least 6 months. Okay, so if it has been quiescent for 6 months, then the pregnancy outcome will be good. Okay, so the waiting period between the start of quiescence and conception should at least be 6 months. Immunosuppression to be continued during pregnancy. Okay, the pregnancy is, pregnancy is one state where the disease can either worsen or can remain silent, or it can remain the same. Okay, so immunosuppression should be continued, and if there is any new onset nephritis during pregnancy, then it should be aggressively treated with IV steroids. Okay, so what is the drug of choice for new onset nephritis? The drug of choice for lupus flare or new onset nephritis is methylprednisolone. Okay, the drug of choice is methylprednisolone. Okay, finally, very important point, what all drugs can be used during pregnancy and what all drugs are to be avoided during pregnancy. Okay, aspirin can be used during pregnancy. Corticosteroids are, the drugs of choice, and they can be used during pregnancy. Azathioprine can be used, and hydroxychloroquine, if required, yes, can be used during pregnancy. So these 4 drugs can be used during pregnancy. Please remember, methotrexate, mycophenolate and cyclophosphamide are drugs which are supposed to be avoided during pregnancy. Okay, methotrexate, mycophenolate and cyclophosphamide are to be avoided during pregnancy. Okay, so here is the question, which is incorrect regarding lupus nephritis in pregnancy. Ecosprin, methotrexate and steroids are safe during pregnancy. This is wrong. I told you methotrexate is unsafe during pregnancy. Okay, methotrexate is an abortifacient, so it should not be used. Immunosuppression to be continued in lupus nephritis, this is right. Pregnancy is to be planned once disease has been quiescent for at least 6 months, this is right. And high dose corticosteroids are safe, this again is right. Okay. So, this is it about this question. So, the last question for this session, this is a very, very rare question, very unexpected question, and all you need to know is only one point, which I will tell you now. A 25-year-old woman with lepromatous leprosy on MDT in pregnancy presents with type 2 lepro reaction. What will you do? So, obviously, you know thalidomide is not used in pregnancy. Thalidomide is a teratogenic drug. It should not be used during pregnancy. Antibiotics have no role here because it is an allergic reaction. No, type 2 lepra reaction is an allergic reaction. So, antibiotics would not help here. Okay. Now, the competition goes between stop MDT and start steroid or start steroid. Okay. Please remember, for type 2 lepra reaction, even during pregnancy, this multi-drug therapy should not be stopped. Okay, anti-lepra drugs should not be stopped during pregnancy. It should be continued along with steroids. Okay, for type 2 lepra reaction during pregnancy, continue the multi-drug therapy and start corticosteroids. Okay, so this is the correct answer. Okay, so hope this session was useful for you. Here we finish this INI CET May 2022 recall session.